Hello everyone, this is Fire Chief Paul Dow with Albuquerque Fire Rescue. This podcast is designed to bring you helpful training and best practices and some additional resources that you can access from anywhere. So thank you for joining us and enjoy today's episode.
Hello everybody, welcome to another episode of the AFR podcast. Today I am joined by Captain Kevin Ferando. Welcome Kevin, how you doing?
I'm doing great, thanks Andrew for having me.
Awesome. So you've been a 7-8 now for a couple of years. How you been liking it so far?
Oh, it's a great spot. Yeah, it'll be official 2 years next March, so not quite 2 years yet. But upgraded in the spot quite a bit before that, so still a lot to learn. It's amazing how much stuff that we do have and to do, and constantly just moving.
Yeah. All right. So what do you think the department sees as the role of 7-8, or how do you see your role as like your primary responsibilities?
Well, our title is QA/QI, and biggest component though is not necessarily all that. It's EMS supervisor. I think is a huge role we play. Clearly, we got all the critical calls, all the arrests, all your major car accidents, shootings. And so I think our position is just kind of an oversight sometimes, and that's not necessarily taking over any kind of scene control, but we're just there for another resource.
Nice. So maybe on a bigger incident, now you guys can actually become a piece to, manage that incident. But if it's a smaller, say just like a 9 Echo, you guys aren't showing up necessarily for patient care.
Correct. The few MCIs I've had, we kind of function either as command, or we transfer that command to a higher rank when they get there, and then we'll kind of segue into a transport triage officer. And so most of our concern is getting those patients off scene, getting them to the appropriate facility, the reds to UNM, as it goes yellow, red, green, kind of see that they get to the facilities that are more capable to handle that. And as far as the 9 Echoes and say, the more calls that we run a lot more in the city, I show up, and then it's kind of just let the crews, the lieutenants or whoever's on scene, just run their call, and I'm just there for a little extra help. And if I see something, then I'll say something. But.
Okay. Yeah. What do you see your role as improving that quality improvement? So if you go to a 9 Echo and you see room for improvement, how do you deal with that?
Well, we debrief. All the 7-8s do it. I think either it's right after the call happens, or we'll do it at the hospital. It's kind of all situation dependent. So there's always going to be learning, ask questions. Hey, what went well on this call? And it's just getting that feedback from crews. If you see something that, hey, we could have done this a little bit better, or hey, I saw that you drew this up, we could have done that a little quicker. Usually most of the time these calls run pretty smoothly, but sometimes you'll see some where they go a little chaotic, and it's for the most part, I feel that the rescue lieutenants do a great job, the engine lieutenants do a great job. Everybody involved is very coordinated, and there's not a lot for me who shows up 5-10 minutes later after the dispatch to these calls that I'm going to impart. It's not for me to show up and just take it away from that lieutenant and say, hey, I'm here now. You can just sit back. It's the opposite. I say, I'm here. What can I help you with? What can we do?
Nice. And take us behind the scenes of like your meetings when you guys all get together and talk about I can't talk about what's behind the curtain.
No. I think it's just a matter of, it's all about improving the department and improving what we do in medicine. We have our QA monthly meetings, we have the medical control board meetings, and there's a lot of email that goes back and forth between our medical director, Dr. Pruitt, and EMS Commander Chris Ortiz, and DC Jaramillo. And so it's just a lot of what is happening in the streets and how is it affecting the rest of the department, what's new to the department, what's new in medicine, and it's kind of coordinating and shifting through all that information and figuring how to get it out to the crews, whether it's improving the SOGs or whether it's just kind of keeping up on what's happening. So there's a lot of information, and the meetings, that's really what they cover. I think the most part of it is what we can do to be better.
And do you guys drive training? Are you able to impact that at all?
We do. I think we try to be as proactive as possible, but a little bit of it's reactive too, just in the nature of our position, in that the SOGs are established or the guidelines are established, and then if there's a deficiency that occurs at that point, it either creates a QA, that opportunity to do that QI part of it, that improvement part of it. And then now that's where the training component starts fitting into that, whether it's the 7/8 it's himself or herself does that training with that person or that crew. If it's bigger, then sometimes we can try to push that to the staff at the fire academy to actually input that into the EMS refreshers, or if it's a big thing like that.
Like a trend, if you guys notice a trend, not just
Sure.
a couple people doing something, it's like maybe that entire department has the wrong idea of what they're supposed to be doing.
Right. Well, like our new CPAPs that came out, that was, we kind of trialed them, and then, now the academy has the mobile training unit, which goes out, and they got everybody up to speed on just the new CPAP with the inline nebs. And so I not necessarily didn't start with the 7/8 spot, but I think it was one of those coordinated efforts where we got the CPAP to trial it. We gave it to a few crews. We get their feedback. Training Academy gets it, and then they pass it to the rest of the department.
And I notice all the 7/8s, they seem a lot busier now than maybe they were 10 years ago around. When I came in 2010, it seemed like they had a little bit more downtime. So what have you guys been doing to get yourself so busy?
I agree with that too. I came in 2005, and I saw a more laid back approach to the 7/8 position. I don't know exactly when the transition happened. I think it might have happened with now retired Commander Soto. It seems like when he took over that spot and the cadre that was there at the time, they became much more proactive, much more involved, took a leadership role as far as EMS in the field. Maybe it was just more of an ownership role, or they really wanted to do better. I mean, as a whole, it sounds kind of corny, but I think that was the intent. They get a lot of training. At the time it started to transition, they were doing the 7/8s were doing a lot of the ACLS refreshers, the PALS refreshers. It kind of changed away from that, but I think as far as the more of getting and improving the guidelines and improving the crews, improving how patient care is done, improving medicine, it really has taken on more of just that proactive role as opposed to kind of a reactive role. So very involved in everything, very involved in the SOGs. It's a pretty busy position.
Awesome. All right. Well, thanks for the update on just, I've always had a couple of those questions about the 7/8 position exactly, of like, how do you guys see your role versus what maybe when you first come in, what do you expect that role to be?
Right.
We're going to get into our topic of the day though. So we're going to be talking about chest trauma today. And we had a previous podcast talking all about bleeding control. So in that podcast, Dr. Pruitt mentioned there's 5 places to bleed to death. Today we're talking about the chest, which is the biggest cavity, and to refresh you on the other 4 areas, the abdomen, pelvis, femur, or out into the street. So those are all the areas that it is possible for you to bleed to death from. So moving into chest trauma, the way we think about chest trauma, we can break it down into penetrating or blunt trauma. So just the most basic question, like what's the difference between penetrating and blunt trauma?
Well, it's just the self-explanatory. Penetrating any time an object goes into the box or the upper cavity and goes into whatever vital organ that it may hit. Blunt trauma is that force. We associate it more with car wrecks, where our body is doing that impact, where it's a flat hit, and can still cause a tremendous amount of injury internally, and it's a lot harder to see.
All right, let's start out with penetrating trauma. So what are the most common probably penetrating traumas that we're going to see in our department?
Gunshot wounds in Albuquerque are probably the most predominant. Clearly stabbings, and then just those weird freak, someone's impaled on something. But I would say the most that we see is probably the GSW.
All right, so we're talking about guns. Anybody who's had any kind of training with guns, one of the first things you learn is aim for the chest. First of all, it's going to be a bigger target for you to hit, and then also everybody knows that it's going to cause a ton of damage. So that's what the military taught me when I was in, 2 to the chest. And why are they teaching that? Why is that such a damaging area to shoot at?
It's just a lot of vital organs. So for military, for yourself and law enforcement, it's neutralizing the threat, and that's the quickest way to do it. Heart, lungs, and as soon as those are impacted by something coming from the outside, There's a lot of things that can be damaged and result in you bleeding to death very quickly. Bullets themselves will fragment. Hollow point bullets will tear apart, and as they're tearing apart, they are damaging a lot of organs in the body. In addition to the damage that the bullet itself is causing, the force that's created by the bullet, just the speed of it, it's causing this like cavitation effect where everything's getting pushed out and then sucked back in as that bullet's entering and exiting whatever it's going into. That in itself will cause damage to the body, the organs, and risk of bleeding out increases dramatically.
Cool. And a reminder for everybody from paramedic school or basics, if you don't remember this from your basic class, just the speed of the bullet. So different kind of weapon like a rifle is going to cause more damage than a lower velocity weapon, and that goes all the way down to like a knife is going to be less damaging than a bullet.
Speed kills.
Yeah, for sure. Same thing with blunt, but we'll get to that later. All right, so now we got this GSW or a puncture wound from a knife, whatever it is. We've got this injury to the chest. How are we going to treat this out there in the field?
Well, initially you're going to make sure that the scene is accessible, and that's where we once we get into that patient, we expose them trauma naked, and then you kind of look for whatever obviously life threat you can treat right now. So if it's a hole into the chest, we're going to patch that hole. We're going to get that person as quickly as we can to the hospital, because what they need is a trauma surgeon. We know what the injury is. It was an outside insult to the body, and all we can do is maintain whatever vitals we have, hopefully improve them with any kind of fluid replacement, and then ER, OR.
Okay. And when you say plug that hole, what are we doing for that?
Well, for us, we'll usually use a VenaGuard or a gloved hand, and we're covering that hole, trying to prevent that sucking chest wound. So we don't want that person to have any more damage than they already have. By us introducing outside air, we run the risk of having that lung collapse. They're probably already borderline or going down the simple pneumothorax. It's that when they progress to that tension pneumo is when it starts getting life-threatening. Okay,
we'll get into that in just a second. Some other things is, we get taught to do the three-sided tape, or I've seen like tape a credit card or something over that wound, but in reality, like if that person is bleeding or shocky, so they're going to be like clammy and stuff like that, the tape is not going to be that great. So yeah, maybe a VenaGuard might work. I've also used a expired defib pad if you're able to get your hands on that, and you can cut that up into a couple different sizes, but that's pretty quick and easy to be able to slap on it. The cops, you might show up to a scene and the cops have already slapped a chest seal on there. There's pre-made chest seals that are just going to be really sticky and cover that.
Those patients sometimes are either pretty sweaty or pretty bloody. So yeah, if it's a messy situation, those seals sometimes don't stick very well. So constant reevaluation of that.
And one thing to remember too is, as soon as you see that gunshot wound, you see an entrance wound, you're going to want to find that exit wound. So again, don't forget to roll that patient over and look for the exit wound.
And that's we talked about trauma naked a little bit, but that's really important. And it really does mean trauma naked. I've missed entrance wounds, exit wounds before, where the patient's bloody, or maybe you didn't remove their undergarments, and you get to the ED, they cut it off, and there's another exit wound.
Right.
And so, not that that's the end all be all, but you want to be as thorough as possible because you want to address those life threats.
Yeah, don't be shy. Everything off, move things out of the way if you need to get a better look, if you need to lift up the armpit and look in there. I mean, you're checking everywhere. Now, what if somebody got shot, say there's a maniac running around with a crossbow or a bow and arrow or something, just shooting people like crazy, and you show up and they've actually still got the arrow in them. What are you gonna do for that?
Well, the first thing is let's not remove that object. Anytime a person has been impaled, whether it's a knife or a crossbow arrow or a piece of rebar, whatever it is, large bulky dressing around that object. If it's through and through, then pad both sides of it. We don't want it to get dislodged, because there's a good chance that if that person's stable on scene with that impaled object, that arrow or object could be holding itself against an artery that it may be nicked. It's just not bleeding out because that object is holding the pressure itself. So that's going to be something that the OR would probably end up removing, and then that way they can repair that damaged artery or whatever it is.
Yeah, and I can imagine a scene you might show up to where that object is just so awkward and in the way that maybe it's possible for you to, like, say it's like a 10-foot long stick or whatever, like maybe you're able to get that a little bit smaller, like we're not removing it or anything, but maybe just the facts of the situation are like that object has to be smaller for you to move that patient around.
We have the benefit here in Albuquerque of having Squad 2, a lot of specialized equipment, and so even if it was a giant piece of steel where something that a crew wouldn't be able to get removed, if machinery injury, they can hopefully either use a torch or, I don't know if it's even possible, cut it. Obviously there's going to be heat associated with that, but if this person has a giant piece of machinery that's impaled in them, we'll have to get some specialized equipment to get it removed. And then transporting could still be an issue. You're going to have to transport maybe in a precarious position where if it's 4 or 5 feet long and you can't get this, whatever it is, smaller, then you'll have to just improvise a little bit.
All right. So these are the different kinds of penetrating trauma injuries that can create a sucking chest wound. Say, what's a sucking chest wound, and how's that going to progress into a life-threatening situation?
Like we kind of talked earlier, it's when you're introducing that outside air into the chest cavity, and it's causing a pressure differential between the outside air and the inside air in your body. So that lung is going to start getting pushed down. And when that lung collapses, obviously you're going to have difficulty breathing. Our vital signs are probably going to start to tank. You're going to become hypotensive. You're going to become tachycardic. These patients are, they're coming to a point where it's going to become very serious. And so those sucking chest wounds need to be either plugged, or will even get more invasive as it progresses to the tension pneumo with needle decompression.
Okay. So how are we going to? What's the line for us if we've got say a simple pneumo? Just because you have a GSW of the chest, you don't have a tension pneumo. What's the line? Where is that where we actually need to decompress that chest?
It's really going to be based on, I think, the vitals. Once that person becomes unstably hypotensive and they're clearly going to have decreased mentation, that's when you're going to have to take that extra step, because this person's near dying. And when that simple pneumo turned into that tension pneumo, all sorts of things in the body are starting to get compressed. That lung that's collapsed and it's pushing over will start pushing on that heart, and when that heart starts getting pushed on, then it's under a lot more load than it normally is. It already has an insult to the body, and so it's probably beating faster to keep that blood flow. Once that has that pressure on the heart itself, it's working even more. It's even working double time at that point to really get the blood through the body, and so you'll start having those late signs.
Yeah. So when it's compressing on the heart, that's going to you got the increased pressure in the thorax. That's going to reduce your preload, so you're going to have less blood in those ventricles actually to pump out. That's where you might see a sign like JVD, although you mentioned before, that's going to be a late sign. Also,
trachea deviation. Yeah, those are all very late signs, and that person is going to be that's an extremely sick patient.
Right, but tachycardia, say tachypnea, hypoxia, cool clammy skin from the hypoperfusion, absent lung sounds.
Oh, right, we didn't address that. They're usually going to have that side, that deficit where it's been impaled or it has that sucking wound. You're going to, since that lung has already been compromised and it's collapsed, you're not going to have lung sounds on that side. So that's going to be one big indicator that this person has a pneumothorax. Now, if it's a simple, or has it progressed to a tension pneumo?
All right, so hopefully you guys, that'll clear it up. We want to do needle decompression on a tension pneumo, not a simple pneumo. So again, we're not just randomly decompressing everybody out there because you want to try to get one of those under your belt.
Well, I think what happens is we have that this person was either hit by a car, so it's a blunt force, or this person was stabbed or shot, and then they might even still at this point be vitally stable. If they're talking, they're tracking, they don't hit the criteria for that tension pneumo yet, that person doesn't necessarily need a needle decompression right now. I'm not saying not to do it, because it's an intervention that can save lives. We just want to make sure we're not arbitrarily doing needle decompression.
And that needs to be high, like at the top of your list of what you're looking for. As that call goes on, you've got massive trauma, like you should be ready, like at any second for that. It should be high on your list. Any kind of car wreck. But yeah, you got to make sure it fits the criteria that we're looking for before you're going to go ahead with that procedure. But transitioning to that, if we are going to go through with the needle decompression, what do you think the most common site is right now?
I think everybody goes mid-clavicular, just 2 down, 2 ribs intercostal, skiving the second rib if you want to get technical, going into that third spot. And that's where I feel that's the most comfortable spot for everyone. Most providers seem like that's where they go.
Yeah.
It's right, the patient's laying supine, and they, just presenting, and it's easy spot to access.
Yeah, so that spot's going to be the second or third ICS. It's going to be mid-clavicular, like you said. I forgot the term you used, but you're going to...
Skiving the second intercostal.
Skiving, oh, there you go. That's
slide
a good,
over it, yeah.
That's a good question. So yeah, you want to walk over that rib because remember, if you go under the rib, that's where the blood vessels are and the nerves and stuff like that. So we want to avoid that. However, there's been some research out there, everybody. So, Kevin and I have these massive pectoral muscles, and sometimes if that's a situation that you're given, that needle decompression is not going to work on us. There's just too much mass.
It doesn't take a whole lot of mass. You'd be amazed that the average size person, how many needle. I don't have the numbers, but I was reading one study that showed how many failed needle decompressions occur mid-axillary under that. That second to third intercostal, just because, some males have a thicker upper body and it just doesn't penetrate all the way into that lung to get that decompression that we want.
Yeah, so if you're out there listening, what I want you to do right now is feel underneath your armpit. I want you to feel your ribs there. Just feel, no matter, how giant you are, you can still probably feel your ribs. So I know now that PJs, for sure, based on that research that Kevin was talking about, they're teaching the preferred site for needle decompression is going to be that 4th or 5th intercostal space at the anterior axillary line, and it's not super specific. Dr. Pruitt had a slide about this that showed what did she call it, the triangle of safety, I think. So
right, yeah, and also there's a lot of vessels too when you start going. When you're mid-clavicular, you have the heart. You have a lot of arteries, and so there's actually a lot of things that we can do damage to if we go too low on that spot. The axillary spot would probably be the spot that we should be encouraging. Less mass, less meat to go to, more direct line of sight to the lung, and a lot less arteries or vessels to hit.
Yeah, and it's going to be. I think it's going to be a little bit easier, versus the other one. You count, the first rib is going to be right below the clavicle, and then you got to kind of, again, try to count down the ribs through all that tissue versus the anterior axillary line. You can feel those ribs a lot easier, and also you just have a landmark, so you can go right about nipple level, or for women, it's going to be the mammary fold, and that'll put you right about the 4th ICS. It makes it easier. Or one other trick we learned is if you put like your hand in their armpit, you just go down below that hand. That'll get you right in
below that pinky, and kind of put you in the spot.
Yeah, that triangle of safety again. So, that's what we're going to try to get out there. And there's study behind this. It's not just our opinion. There's research behind this that is saying that's going to be a preferred spot. Okay, Kevin. So, say we just did a needle decompression at the appropriate time, but the BP didn't come up after that. Is there anything else we're going to be able to do for that patient?
Rapid transport. It looks like that's probably going to be more of a hemorrhagic shock. That person's probably bleeding out internally. So, the tension pneumo is what we're trying to fix to hopefully make everything better. But if it doesn't fix it, then it's probably more damage internally than what we can do. So that person's still going to need an ER, and then more likely the OR.
Okay, so what else can we do en route? With fluids or things like that.
We're gonna have 2 large bore IVs in place, and it's gonna be fluid resuscitation to maintain at least a systolic of 100. But we don't want to get their. We're not trying to get their pressure back to normal because we know what the problem is. They're bleeding internally. We don't need a 120 over 80. We're just trying to keep that pressures up to where we still have pulses and keeping that person alive.
Yeah, if you get that pressure too high, any kind of clots that have been starting to form, you could resuscitate them to their pressure is too high, and now it's going to bust those clots open. Also remember that hypothermia is going to be a big killer in these patients, so keep them covered after trauma naked, but then you got to remember to cover them back up.
Trying to prevent that hypothermic state for these
Yeah.
guys.
All right. And then, the ultimate treatment for this person is going to be a surgeon. All right. I think we covered penetrating trauma pretty good. So we're going to move on to blunt trauma. So some of these injuries, the mechanism could be MBAs, a fall, a bat, punched. All these are going to be blunt force trauma. So what do you think? What's the biggest thing we need to know about blunt force trauma as far as like the extent of the damage? Like,
Speed kills. And that's going to be those acceleration, deceleration injuries where, that person comes to a blunt stop or something hits them at a really fast pace. And the injuries internally are going to be all over the place. Torn aorta, there's a tendon that develops just slightly after you're born. And it's the ligament that holds your aorta in place, and it keeps it there. It's rigid. So when the body moves or stops relatively quickly, it will tend to shear or tear that aorta. Those individuals are going to be extremely hard to save because there's a lot of blood that's getting pumped in that aorta, and they're going to bleed to death probably in a minute or two. So that's going to lead us down to that trauma arrest kind of patient. But as far as a lot of the other injuries that we can help, those patients are going to be the ones that are still fairly stable. There's going to be some outward signs, MVAs. You might have to see the seat belt mark, steering wheel marks. These are, going to give you kind of indicators that this person definitely suffered some injury just from the outward look. So you can assume that internally there might be something going on as well.
all right. And some of the internal things, we already talked about them. You can still have a pneumo from blunt force trauma, right?
That's correct. Yeah, it can cause that lung to get collapse. Fluid can build up around it. We start leading down the hemothorax, the cardiac tamponades, all the other injuries that are going to be as a result of more than likely a bleed.
Okay, so let's talk about the difference what's the difference going to be between like a tension pneumo and cardiac tamponade? They're still, it's kind of, both of them are like putting pressure on the heart, just in like a different way kind of. So can you explain the difference between those two?
Sure. The key is going to be the listening to lung sound, so that we have to oscillate. If you have no lung sound, we're going to be index of suspicion that it's going to be that tension pneumo. If we hear muffled heart tones, then that's when we're starting to think that it might be that cardiac tamponade, that fluid or blood building up around the heart and just reducing the preload.
Okay. Everybody out there, if you got to take a paramedic test anytime soon, just remember Beck's triad. So Beck's triad, you're going to have muffled heart tones, JVD, and hypotension. And I don't know, I just always remember that. I don't know why. It's just a random name of a triad. There's lots of them.
That's very good stuff to memorize. We're going to be using Beck's triad every time now.
There we go. So muffled heart tones, pay attention to it. Right, but really.
But the lung sounds. That's the absent or present lung sounds.
Right. Okay. And some of the other injuries we can get some fractured ribs, flail chest, pulmonary contusions. You already talked about the deceleration injury.
We don't want to forget commotio cordis.
Oh, there we go. Another good one.
Disruption of the heart from a blunt force trauma. It happens a lot of times, like Little League, baseball to the chest. Ball hits center chest at the exact time the heart's beating, causing a person to go from a, say, normal rhythm to VFib.
Okay.
So,
and
not very common, but it does
with
happen.
that, like a cardiac contusion, so just, somebody's not wearing their seatbelt, they come forward, they hit the steering wheel. You can have all these injuries that we've talked about. Again, this is all blunt force, but with a cardiac contusion, just be suspicious of an arrhythmia. So getting that patient on the monitor, or with the commotio cordis. So that's another one.
You just wanted to say it too,
right? I'll put it in my memory bank, and I'll pull that out anytime.
But these patients are sick, and they really need to get to the ER quickly. So repeat vitals, just constant evaluation of our patients, and then rapid transport.
Okay. The thing to remember, again, we talked about the 5 places you can bleed to death. If they're bleeding out into their chest, that is not something we're going to fix in the field. So getting them to that surgeon as quick as possible. I think a lot of people learn pretty good from stories. So we have
there's always lots of stories.
We have story time a little bit. You got any good examples of like a blunt trauma or penetrating trauma to the chest?
I had one blunt trauma. This was years ago. It was an elderly lady in the rear seat of a vehicle and a pretty minor MVA, 35 maybe miles per hour. We get there on scene. She doesn't look great. She's talking. She's ANO times 4. She's out of the vehicle. She's just kind of complaining about some diffuse abdominal pain. And, you know, you get that kind of that sneaking suspicion, like this person looks a little bit more critical. It was one of those, I don't remember what I was on, Rescue 3 or whatever it was, but it was just off the freeway. It was right by the mall. And so we were getting ready to load her and go. AES shows up, kind of give the quick debrief. Hey, this lady doesn't look good, pretty low MVA, but her vitals, she was a little hypotensive. Not bad, but there was just something, you get that feeling like, well, this person just doesn't seem 100% right. So outwardly, really not a lot of injuries. I don't remember there being a seatbelt mark. So we get her loaded up, we transport her to ED, get an IV started. Pressure comes up, vitals are really good. She's in the ER and she's a really stable patient for the most part from what we're looking at. I get a call about 20 minutes later that she crashed and did not make it. So she had a bleed. She had a lacerated liver, and it bled out on her way to the OR. And so, you know, you look at this patient though on scene, you're kind of like, well, you know, there's not a lot of the mechanisms there, but was it enough? You know, you start looking at the age group, that geriatric patient, and so would there have been anything we could have done differently? I don't think so, because we got transport initiated immediately. I know the ER was a little bit kind of like, well, this person's pretty stable, and then they weren't.
Yeah.
So that maybe not, she just decompensated very quickly. So they couldn't catch it. Probably wouldn't have made a difference. But, you know, don't let that fool you. Take them all very seriously is the kind of the moral of the story.
Yeah, that mechanism should just get your heart rate going a little bit. You should not be wasting time on scene when you got a serious mechanism. You bring up that, what did you think it was, a lacerated liver?
It was, I believe, a lacerated liver. I think there might have been an artery and some artery that internally that was affected as well.
I'm gonna have to look that one up. We're having an abdominal trauma coming up, and there's a ligament in there too.
That one I don't know.
It's not the ligamentum arteriosum, but I'm gonna have to. I'll figure that one out for the next podcast because I'm not familiar with that. But how about any kind of like shooting, stabbings? I'm sure you've seen a lot of that, but
we all have
stand out.
If you're in Albuquerque and you've done medicine for a year or two, you'll have seen quite a few, you know, the penetrating traumas. I've found that a lot of the actually fairly stable. It's surprising how many people do get shot, and you know, you're kind of like, wow, this person's actually doing fairly well. Especially those ones where you get there, they're ANO times 4 still, they're talking to you, you know, they're in bad shape. That's when you just start doing the whole, you go down the trauma, the algorithm, where, you know, let's just start at the top and work our way down. Trauma naked, you know, looking for entrance wounds, looking for exit wounds, plugging what we can plug, patching what we can patch. Do we need to do a needle decompression? Are they starting to deteriorate? Do we have to go down that? This person, you know, clearly we just reassess, get those vital signs, and then treat the obvious wounds. And then the external injuries to the, you know, the extremities, that's just going to be that high tourniquet, high and tight, and, you know, don't let it be distracting. Let's focus on those vitals and fixing what we can fix en route.
Awesome. Well, we're going to wrap it up, but do you have any advice for people? You know, this one, again, this is medical intensive, but even for the basics out there that want to become better at medicine, you know, what's your thoughts on just improving?
You know, I think in general with trauma, just if you see it, fix it. You know, there's a lot we can do. And so it doesn't matter what your licensure level is to put pressure on a wound, to, you know, cover up with a gloved hand a sucking chest wound. You know, we're prepping this person to get them to the OR. That's really, definitive care is the only thing that we can do to help this person. And really just is that first on scene provider, good BLS. You know, we can do a lot real quickly, and just working towards packaging.
Yeah.
Working towards packaging, working towards transport, and that's about it.
All right. Everybody, thanks for listening again. We covered chest trauma today, and once again, I was joined by Captain Kevin Ferando. So thanks for coming on, Kevin. Appreciate it.
Absolutely, Andrew. Thank you very much.
All right. Everybody out there, thanks for listening, and talk to you on the next episode.